Welcome to the deep dive. Anyone who's spent time around kids will know there are certain illnesses that just seem to constantly do the rounds.
Yep, definitely.
So today, we're going to get a really clear handle on one of those classic childhood conditions, hand, foot, and mouth disease, HFMD.
Yeah, it's a really common one.
It feels like something you really want to be able to recognize and, understand whether you're looking after kids or working in healthcare.
Exactly. And you've given us a great set of revision notes on HFMD to work from today.
That's right.
So our goal, really, for this deep dive is to take all that info, pull out the absolute key bits, and make it stick. Give you the knowledge you need quickly and hopefully effectively.
Okay, fantastic. Let's dive right in then. What exactly is hand, foot, and mouth disease? What are we actually defining here?
Okay, so simply put, HFMD is a viral illness. It typically hits young children the hardest.
Right.
And the real giveaway. Usually these sores or little blisters that pop up on their hands, their feet, and often inside their mouths too.
Ah, hence the name.
Precisely. It's caused by a group of viruses, specifically enteroviruses. The main ones you hear about are Coxsackie A16 and Enterovirus 71.
And it's really famous for being contagious, isn't it? Feels like you always hear about outbreaks sweeping through nurseries.
You're absolutely spot on there. Highly contagious.
Yeah.
That's why it just spreads like wildfire in places where kids are all close together.
Makes sense.
Now, these viruses, they belong to a bigger family, the enteroviruses, which are RNA viruses. And within that group, you've got different types like Coxsackievirus A and Coxsackievirus B. Think of it like a big family tree.
Okay, got it. So the notes highlight Coxsackie A as the main one for HFMD itself. What about Coxsackie B? What does that tend to do?
That's right. Coxsackievirus A, especially types like A16 and that Enterovirus 71 we mentioned, they're the primary culprits for what we classically see as HFMD.
Okay.
Coxsackie B, on the other hand, tends to go for other parts of the body. It can affect the heart, the lungs, pancreas, liver.
Oh, interesting.
Yeah. And what's quite interesting is that both types, A and B, can sometimes lead to other problems like aseptic meningitis or various respiratory illnesses. So while A is the usual suspect for HFMD, both can cause different kinds of trouble.
Okay, so they're quite versatile then, these viruses. How do they actually get around? What are the main transmission routes?
Well, the main ways it spreads are what we call Faeco-oral and oral-oral.
Right.
So basically, think about young kids. Hygiene isn't always their strong point, is it? The virus can be in their poo, and if hands aren't washed properly...
It gets everywhere.
Exactly.
Yeah.
Surfaces, toys, then into another child's mouth. And it's also in saliva, nasal secretions, even the fluid from the blisters. So close contact, sharing cups, kissing, all that spreads it too.
And how long does it take to show up after exposure?
The incubation period is usually around 2 to 6 days, give or take.
Okay. And that name, Coxsackie. It's quite distinctive. Where does that come from?
Yeah, it's actually named after a place, Coxsackie, a town in New York State. That's where these viruses were first isolated back in the day.
Huh. A little bit of history. Cool. So just to recap the cause, the etiology. It's these enteroviruses, mainly Coxsackie A16 and Enterovirus 71. What makes them quite so good at spreading around?
It really comes down to how easily they're transmitted. Like we said, close personal contact is huge.
Right.
Then you've got respiratory droplets, coughing, sneezing, that's another route. And direct contact with contaminated surfaces. Think toys that have been slobbered on. And, of course, contact with infected feces. It's this combination that makes it just so darn infectious, especially among kids.
And speaking of kids, who is most likely to get it? Are there specific risk factors?
Definitely. The group most at risk by far is children under 5 years old.
Okay. Why them specifically?
Well, their immune systems are still maturing, so they're just more vulnerable to these types of viruses.
Right.
And environments where lots of little kids gather, daycare centers, nurseries, preschools, those are hotspots for obvious reasons. Crowded settings just increase the risk. And, of course, just being in close contact with someone who's already infected or touching things they've contaminated, that significantly ups the risk, too.
Okay, that all makes sense. So the virus gets in. What happens next, pathologically speaking? What leads to those blisters and the fever and everything?
So the virus usually enters the body either through the respiratory tract, breathing it in, or by ingestion. Like a child touching a contaminated toy, then putting their hand straight in their mouth.
Standard kid behavior.
Pretty much. Once it's inside, the virus starts replicating, multiplying. And it's this replication process that triggers the body's immune response and leads to the symptoms we actually see.
And where does it primarily set up shop?
The main tissues it targets are the skin causing those blisters, the mucous membranes, especially inside the mouth, leading to those painful sores,
Yeah.
and also lymphoid tissue, which is part of the immune system itself.
Right. So if a child presents with these symptoms, what else might be going on? What are the key things to rule out the differential diagnoses?
That's a really important point. There are a few other conditions that can look, well, a bit similar.
Like what?
One key one is herpingina. It's also caused by enteroviruses, and you get blisters in the mouth. But crucially, you don't usually see as much involvement on the hands and feet.
Okay, so location matters.
Absolutely. Then there's chickenpox, caused by the varicella virus. That's another possibility. But the chickenpox rash is typically much more widespread over the whole body, and the blisters tend to crust over in a characteristic way.
Gotcha.
And then you've just got a sort of broader category of other viral exanthems, basically, other viral illnesses that happen to cause a rash. Distinguishing them often comes down to the specific pattern and the location of those sores or blisters. HFMD has that very typical distribution.
Okay. Let's talk prevalence. How common is HFMD, particularly thinking about the UK? What's the epidemiology look like?
It's very common, a really common viral illness globally, and the UK is certainly no exception.
Right.
We tend to see peaks in outbreaks during the warmer months. Yeah. And as we've said, it overwhelmingly affects children under 5. That's the prime age group.
Yeah.
The actual incidence can fluctuate a bit year to year, but it's consistently around, mostly hitting kids under 10.
But adults can get it too.
Oh, yes, absolutely. It's much less common because most adults have probably encountered these viruses before and built up some immunity, but it can happen at any age.
And where do outbreaks typically happen here?
Nurseries and schools.
Yeah.
Definitely the most common settings in the UK, simply because of the close contact between young children.
Right. So clinical presentation. What will parents or caregivers actually see? What are the signs and symptoms to look out for?
Okay, so typically it starts with a fever and often a sore throat. Kids might go off their food, seem a bit lethargic, or generally unwell, what we call malaise.
Yeah.
And then comes the main event, those painful sores or small blisters. They classically appear on the palms of the hands, the soles of the feet, and inside the mouth, think tongue, gums, inside the cheeks.
Painful ones in the mouth, I bet.
Oh, they can be really uncomfortable, yeah. And sometimes you might also see a skin rash, often non-itchy, elsewhere on the body, along with these main symptoms.
Okay. Now, the notes briefly touched on some other conditions caused by these Coxsackieviruses. We're focused on HFMD, but is there anything sort of key from those, just for context?
Yeah, it's useful just to be aware of the range. So herpingina, for instance, also an enterovirus thing, usually has a quicker incubation, maybe 4 days. Mostly kids under 10 again. Fever, headache, sore throat, and these little gray-white spots, usually at the back of the mouth. Clears up in about a week, normally.
Okay.
Then there's Bornholm disease, caused by Coxsackie B. That one's sometimes called devil's grip because you get this really intense chest pain, worse on breathing, plus muscle tenderness, fever, maybe tummy pain.
Wow, sounds nasty.
It can be quite unpleasant, yeah. So these just show the Coxsackie family can manifest in different ways. But for HFMD, the key is always that specific hand, foot, and mouth pattern.
Got it. That puts it in perspective. So back to HFMD itself.
Yeah.
How is it normally diagnosed? Are specific tests usually needed?
For the vast majority of cases, diagnosis is clinical. Meaning the doctor recognizes it just based on the classic symptoms, the combo of fever, plus the sores and blisters in those typical places.
Yeah.
Hands, feet, mouth.
So tests aren't routine?
Not usually, no. Not for straightforward cases. Lab tests are available if needed for confirmation, or maybe in an outbreak situation. You can take swabs from the throat or the blisters or get stool samples and try to isolate the virus.
Okay.
There are also blood tests like an IgM ELISA that look for the body's immune response. Or in specialist centers, they might use PCR to identify the exact enterovirus subtype.
Yeah.
But again, usually not necessary day to day.
Right, okay. So mostly a visual diagnosis based on the pattern. What about managing it then? Is there a specific treatment?
Unfortunately, no. There isn't a specific antiviral drug that targets the HFMD viruses effectively.
Ah, okay. So what do you do?
Management is all about supportive care, relieving the symptoms, making the child comfortable.
Right.
Hydration is really key. Making sure they drink plenty of fluids, especially if those mouth sores are making it painful to swallow.
Yeah, I can imagine that's a problem.
Definitely. And pain relief, simple stuff like paracetamol or ibuprofen can help bring down the fever and ease the discomfort from the sores.
And what about keeping kids off school or nursery?
That's a good question. Current public health advice often suggests that exclusion isn't always necessary if the child is well enough in themselves to be there, if they don't have a high fever and feel okay, but always best to check local guidance.
Okay. And anything specific for those painful mouth sores?
Yeah, they can be the trickiest bit.
Could you-
Again, fluids are priority number one. Pain relief with paracetamol or ibuprofen as needed. And sometimes topical things might help a bit, like anesthetic mouth gels or sprays designed for teething or mouth ulcers, just to numb things locally.
Worth a try, maybe.
Might give some temporary relief. But just to reiterate, antivirals are generally not indicated for standard HFMD. There are rare exceptions for severe complications, like myocarditis from Coxsackie-B, but that's very different.
Understood. And what about pregnancy? Any specific worries or advice if a pregnant woman catches HFMD?
Generally, the evidence suggests HFMD itself isn't likely to harm the developing baby, so mostly reassurance.
Okay, that's good.
However, if a woman gets it very close to her delivery date, say, within the last 3 weeks of pregnancy, it's sensible to let her midwife or doctor know. There's some limited data suggesting Coxsackie-B infections might slightly increase risks like miscarriage or issues for the newborn, but it seems pretty rare. Specialist advice is key near delivery.
Right. Okay, let's talk outcomes. What's the usual prognosis for a case of HFMD?
Oh, it's excellent in most cases, really good. Symptoms typically clear up completely on their own within about 7 to 10 days.
So self-limiting usually.
Exactly. Serious complications are uncommon.
But they can happen.
They can, though, rarely. Things like dehydration, as we mentioned, if fluid intake drops too low, secondary bacterial infections, if the blisters get infected, and then very rarely neurological things like viral meningitis or encephalitis, inflammation of the brain lining or brain itself.
Okay.
And one slightly odd thing you sometimes see is temporary nail shedding. Fingernails or toenails might fall off a few weeks after the illness. Looks alarming, but they grow back fine.
Huh. Weird.
Yeah. But overall, for Coxsackie-virus infections generally, including HFMD, the prognosis is very good. Even aseptic meningitis usually resolves fully. Encephalitis is more serious, of course, but thankfully much rarer.
And things like the heart inflammation from Coxsackie-B?
Usually a good prognosis too, but there is potential for longer-term issues in some cases. It's also worth mentioning that there's work being done, especially in places like China, on developing vaccines against the main HFMD enteroviruses. So prevention might improve in the future.
Interesting. So just to focus on the complications again, even though they're uncommon, what are the main red flags?
The main ones to be aware of are dehydration signs like drowsiness, not passing much urine, dry mouth, secondary bacterial infection if the sores look very red, swollen, start oozing pus, or become much more painful, viral meningitis, severe headache, stiff neck, dislike of bright lights, encephalitis confusion, seizures, severe drowsiness, which is obviously very serious, but again, very rare, and that temporary nail loss we mentioned.
And if any of those are suspected?
Seek medical attention promptly. Definitely. Right. Don't delay if you're worried about complications.
Okay. This has been incredibly clear. Now, to help all this information stick, any useful memory tips or maybe an example question for us?
Absolutely. Let's try a simple mnemonic for the main symptoms. Just think. Feet, hands, and mouth. FHM. Easy, right?
Feet, hands, mouth. Got it.
And often there's that initial fever, too. So maybe FHM plus F.
Nice. I like that.
And remember, the key viruses Coxsackie A16 and Enterovirus 71 are the main ones for typical HFMD. For spread, think oral and Faeco-oral. Hygiene, hygiene, hygiene.
Okay. FHM plus fever, A16 and EV71, oral and fecal routes. Good summary. How about that example question?
Right. Let's test you. A 3-year-old child attending nursery presents with a moderate fever, complains of a sore throat, and on examination you find small blisters on their palms, soles, and inside their mouth on the buccal mucosa. What's the most likely causative organism or organisms? Give it a thought.
Okay. Based on everything we've just discussed. Classic presentation. Nursery setting.
Okay.
Got to be Coxsackievirus A16 or Enterovirus 71.
Bang on. Exactly right. You've nailed it.
Excellent.
And just a quick tip for thinking about differentials. Remember the distribution. Chickenpox, usually all over. Herbigina, mainly just the mouth. HFMD has that signature feet, hands, mouth pattern.
Makes sense.
And management focus. Keep it simple. Supportive care. Fluids and pain relief. Hydration and analgesia.
Great tips, thank you. So just to quickly recap then, we've defined HFMD, talked about the main viral causes, Coxsackie-A, Enterovirus 71, how it presents with that classic fever and sores on the feet, hands, and mouth, and that management is really about supportive care.
Precisely.
Yeah.
That's the core of it. The aim today was really to distill those revision notes into a clear, high-yield overview for you, hitting the key points needed for understanding and, well, for remembering it too.
Mission accomplished, I think. And if listeners want to explore this or other pediatric topics in more detail, where should they head?
Yeah, for more in-depth revision and learning, PassTheMSRA.com and FreeSRA.com are absolutely fantastic resources. Highly recommend checking them out.
Excellent. We'll make sure those links are available, PassTheMSRA.com and FreeMSRA.com.
Great. Well, on that note, thank you so much for joining us for this deep dive into hand, foot, and mouth disease.
My pleasure.
It's such a common thing, but actually having that solid grasp of the details is really valuable.
It really is. And, thinking about how easily these enteroviruses spread and the sheer range of illnesses they can cause, it does make you wonder, doesn't it? What are the most effective, broader public health strategies we could use to really minimize the spread of these common childhood illnesses in our communities? That's a really important question to ponder, something for us all to think about. Thanks again for joining us on the deep dive.